obviously of interest to all of us, especially to those who don't like doing trabs and tubes, because it's kind of a way out, or a potential way out, for those of us who don't like doing laborious procedures that require intensive follow-up. It's still not a perfect alternative, but you've got the Zen and the PreserFlow, which I think everyone knows by now what a Zen looks like. It's been around for more than 10 years. And it does have the potential to give good pressure control and nice blebs. The trouble that we had with the Bleb, with the Zen, really was the high rate of dysesthesia and very anterior avascular blebs, which, to my mind, in many patients were worse than mitomycin trab blebs. So you weren't really reducing the risk, and we certainly had a few cases of Zen-related endophthalmitis. And on top of that, Zens, because they're ab interno insertion technique, there is a propensity to get caught in tenons and not drain. And needling became almost routine with Zens. And sometimes it worked. But needling Zens, I must say, was not something that I really ever enjoyed doing, and I always felt it was a bit like feeling the force. You couldn't quite see what you were doing. And there were many cases where, like this, where you can free the Zen, but you've got fairly low chance that you're going to get decent long-term pressure control if you're getting this amount of scarring. And often with needling, and the only fluid that I got was blood. So overall, I was never quite happy with needling Zens, and open revision tended to be a preferred technique. Now, I'm being a little unfair to Zen comparing it with PreserFlow, because PreserFlow is an easy technique as well, except that you've got to open the conjunctiva and apply mito. But I think if we did Zens the same way, we probably would get similar results. But the Zen, and a number of colleagues in the US do Zens ab externo. Now, I've been doing PreserFlow's ab externo, where I've been doing Zens ab interno. And I think the approach has has more effect, more influence than the actual device. And with the PreserFlows, you don't get the limbal avascular blebs, you don't get the dysesthesia, simply because it's a more posterior bleb. And it may be that if you do the Zens the same way, you'd get the same results. This is a speeded up PreserFlow implantation video that I did for Santen. I've just doubled the speed, otherwise you'll all get very bored. I think most people have probably seen the PreserFlow implantation technique. It's not that difficult. The only thing that actually requires any skill at all is getting the device to sit in the right place in the anterior chamber. And you've got to go in quite carefully and not distort the tissues too much, and get it to lie away from the cornea but not in the iris. And any device that you put through a long tunnel is a little harder to position accurately. But overall, this is a simpler technique than a trabeculectomy. It's quicker. It has fewer variations. There are some tricks. You've got to make sure that the tunnel is formed accurately, or you won't get it into the eye. It's hydrophobic, so you do have to exert some pressure to get it to drain. And you do have to make a clinical judgment as to whether the drainage is appropriate, because no matter what any company tells you, every device that exists has a tolerance. It's a variability in manufacture. And some batches will drain faster than others, and some batches will give you hypotony and others won't. So you've just got to make a call on the table as to whether this is an appropriate amount of drainage or not for your patient. And if it's a patient who's highly myopic, who is very elderly, you might want to consider whether the drainage is too much. But what I've shown here are more typical rates of drainage. You also have to take care when closing not to block the device, and that's why we tend to do quite a large peritomy. It's tempting with a small device to do a very small peritomy, but then you can't actually see where you are when you're closing, and you've really got to make sure it doesn't block. But afterwards, I have to say that pressure flow gives the best blebs of any device that involves any kind of limbal drainage. They're posterior. They don't tend to cause dysesthesia. Yes, we have seen one infection, I think, of blebitis, but it seems to be rare, and these are nice. However, now this is what happens if it's draining too much. You can obviously stent them or put in a ripcord. And this is what I was saying, is you've got to make a call on the table as to whether too much is coming out or not. And putting in a ripcord is a very simple way of preventing over drainage. So you first have to look at the drainage carefully, and I think in this case that's coming out a bit too quickly. That's way, way more than 2 microliters a minute. And if you have a very highly myopic, look at that one. You know, if you've got a very highly myopic patient, or a patient who you think is at any risk from developing a hypotony, a stenting technique where you put a ripcord up the tube that can be removed easily at the slit lamp later gives you a safety net that prevents early hypotony without any serious hassle, other than the fact it takes 5 minutes more in the operating theatre. I've tended to use 9-O-proline because it fits nicely inside the tube. But again, if you've got one that's over draining, you probably find 9-O-proline's adequate. I usually do an anchoring bite close to the tube, and the reason for that is that I had one patient where when I pulled out the ripcord, it actually dislodged the tube, whereas if you've got an anchoring scleral bite, it doesn't dislodge the tube, and it also pulls the tube down towards the sclera a little bit so it's not sticking up. So the anchoring scleral bite's quite a handy adjunct, and best positioned close to the tube aperture. As I mentioned, I tend to use 9-O-proline, but it's not one size fits all. Occasionally you'll find 9-O-proline is tight and only goes in a little bit, in which case I tend to use 10-O-proline. Other people have used 10-O-nylon, which is fine as well. The reason I like proline is that it's a bit stiffer and it doesn't degrade, so if you want to leave the stent in forever or take it out after a year or two, it won't have degraded. Now you can see that 9-O-proline's gone most of the way in, and there's a little bit of drainage, but not too much. So that's just about perfect to my mind. I can't see that that's going to cause hypotony. This one is too tight. You can see there's no drainage at all. So that's not what you want either. So you want to pull it back a little bit and just get a little bit of drainage. There's no point occluding it completely. You're defeating the object. And that's what I mean. And you have to make sure that the eye is well inflated first, because if you've got a soft eye, then it's completely different. Now here you can see the proline was only a tiny bit into the tube. So then you might switch to a 10-O. As I say, I tend to use 10-O-proline, but I use 10-O-nylon here as an example because many people do use 10-O-nylon. As I say, I like the proline because it's stiffer, and also it doesn't degrade, whereas nylon will degrade. Irrespective of the type of ripcord, you've got to be obviously careful that you don't dislodge the tube or dislodge the ripcord when you're closing up. And then you can see the loop post-operatively, and I leave it in the cornea to make it easier to pull out, like a releasable suture. And we wrote up, this was actually a description in Eye a couple of years ago. It was actually, these were for pressure flow revisions. Originally we used the ripcord when we were revising pressure flows, but then we started doing it for primary procedures. And the point about the ripcords is initially when we were only using 0.2 milligrams per mil of mitomycin, hypotony was rare. But it rapidly became apparent with pressure flows that you've got to use higher doses of mitomycin, and then the risk is higher. So moving to the higher doses of mitomycin, I started using the ripcords. Now, if we look at our registry that I mentioned yesterday, we looked at TRABs versus PreserFlows versus Zens in this. This is an initial analysis that Nathan Kerr's kindly produced. And you can see that the blue, the TRAB, is getting pressures of around 10, whereas the PreserFlows and Zens, it's still pretty reasonable pressure drop, but it's closer to 13 or 14. So if you do really want the lower pressures, you've got to go for the TRABs, although you might note here the TRABs do start with a lower starting pressure, which may actually reflect our clinical preferences, which is to do TRABs in people who might be abnormal pressure glaucoma and need lower target pressures. And in terms of medication, you can see that the TRABs, the Zens and PreserFlows are doing fairly similarly in terms of pressure, but the PreserFlows are doing better in terms of medication, which is interesting. But overall, the TRABs still ahead of the game. So if we looked at the registry PreserFlows, and this was an analysis I did about actually a year and a half ago, and so the numbers are greater now, but I haven't reanalyzed. But if you look at the graphs, the pie charts on the left, the top is a target pressure of 15 or less, the bottom is a target pressure of 12 or less. With lower doses of mito, you're getting 63% below 15, or 15 or less, and 34% to 12 or less. So with low doses of mito, you're not really doing as well as you'd like. If you up the mito doses to 0.4, 0.5 milligrams per ml in sponges, you're getting 78% at 15 or less, which is, reasonable, and 54% getting 12 or less. So that's up to 0.4, 0.5 milligrams per ml of mito on sponges for 2 or 3 minutes. However, if you look at the TRABs in the registry, there's still a way ahead in terms of pressure control compared to Zens or PreserFlows. They're miles ahead. If you want a pressure of less than 21 with a TRAB, you're 99% less likely to achieve it. If you want a pressure of less than 12 with a TRAB, you're still 81% likely to achieve it. And these TRABs, the vast majority had only 0.2 milligrams per ml of mito, so they're getting much less mitomycin than the Zens, than the PreserFlows. Much less mitomycin than PreserFlows and much higher success rates. And the PreserFlows, in their turn, were doing better than the Zens. So yes, if you do not have TRABs and tubes in your portfolio and you're stuck with MIGS, then PreserFlow does seem to be the best option. However, like TRABs, my feeling is that PreserFlow is very sensitive to case selection. And I see people telling you that you can do PreserFlows after silicone oil and all sorts of stuff. And personally, I think this is rubbish. My first approach with PreserFlows, I don't do them in black patients, Afro-Caribbeans. We have a lot of Nigerians at Moorfields, and it's very, very difficult to get any subconjunctival MIGS to work in an Afro-Caribbean. And if one fails, don't do the same thing again, which people do, because that's just stupid. Now, in India, I always regard Indian patients as being somewhere in the scarring between the Africans and the Caucasians. In my experience, I get Indian patients who are very high scarring, and I get Indian patients who are very low scarring. Now, how to predict who will do what or how in an Indian patient is difficult. And I think, I don't have any scientific basis for this, but anecdotally, I've had more hypotenuse TRABs in Indian ladies and more failures in Indian men. And I don't know, it must be more than just gender difference. There must be lifestyle difference or something. And my Indian colleagues can correct me if I'm wrong, but that's just my personal experience, that the subconjunctival MIGS will probably work pretty well in Indian ladies, but I'm not sure about the men. Tanuj, you can throw me out if this is completely, but that's my experience. What do you do if they fail? And this is the question. I've been doing revisions simply because I have a curiosity to know what's going on. Are we out of time yet? Tell me when to stop. I usually dissect the tenons off without breaching the capsule, put on the mitomycin first so it doesn't go into the anterior chamber. Okay, we're out of time now. So I tend to revise them. I tend to open them up, put on mito and close them up again. It's exactly what I did with Zens. The trouble with that is a proportion will fail. And this was 30, this is a report of 36 PreserFlow revisions we did. And we get modest results, but it's probably not as good as taking the thing out and putting in a tube. The question is really, of the PreserFlows that you revise, what proportion will you get away with not doing anything more in? And this is what I don't know. I suspect that it's 50-50, that 50% do okay and the other 50% need a tube. The problem is whenever you revise them and then have to do a tube, you're onto your third conjunctival operation. So then they start getting a lot of scarring and ptosis, and I've had more double visions from tubes that have had previous PreserFlows and PreserFlow revisions than I would do from primary tubes or tubes after trial failure. So there's questions that need to be answered there, and I'm not sure what the answers are. Anyway, thank you very much for your patience and attention.